lecture. Now we'll go to the next lecture with Professor Dr. Ramy Mansour.
Thank you, everybody, and thank you for attending and being patient with us. I will cover the other side of the peripheral seronegative arthropathy, which already Dr. Leonard mentioned about the axial one. This is the outline of my presentation. I'll just go through the definition and types of seronegative arthropathies, the pathophysiology, the peripheral, or they call it appendicular seronegative arthropathy, and a summary. So just an overview, what do we mean by seronegative arthropathy is a group of chronic inflammatory disease that share the same clinical and some radiological features. By definition, because they are seronegative, that means they are negative for rheumatoid factor, and they include this type of diseases, the psoriatic arthritis, ankylosing spondylitis, and undifferentiated and reactive arthritis. And they are a clinical diagnosis because most of them, represented by pain and stiffness. And this is just a quick overview of the different types of seronegative arthropathies. And you can see most of them share similar appearances with some differences. And you can see the axial seronegative arthropathy, all of them involve the spine and the sacroiliac joint. That's why the sacroiliac joint is very important and crucial in diagnosing seronegative arthropathy, as shown by Dr. Leonard Jans. But also the other one is what we call the appendicular, which is mainly involved the psoriatic, reactive, and enteropathic type of seronegative arthropathy. So in another classification, or a newer classification of seronegative arthropathy, they can be differentiated to axial and peripheral, as you can see, and the axial could be non-radiographics and radiographics. And we are concerned, in my talk, we are concerned about the peripheral seronegative arthropathy. And you can see on the right side of the slide, the diagnosing, it really mainly depends on the clinical appearance of those patients with some changes, mainly in enthesitis and dactylitis and some arthritis. So this is how we clinically, or the rheumatology doctors or physicians diagnose seronegative arthropathy with the help of imaging or radiologists. So what is the hallmark or features of peripheral seronegative arthropathy? So the main hallmark is enthesopathy that we come across on those patients. Sometimes we can see hyperostosis, dactylitis, synovitis, tenosynovitis, and bone erosion, pericystitis. But by all means, the hallmark of seronegative arthropathy is enthesopathy or enthesitis. Just a quick overview about what we mean by enthesopathy or enthesitis. The enthesis, as an anatomical structure, is the attachment of tendon, ligament, or joint capsule into the bone. And there is two types of enthesis: the fibrocartilaginous, the fibrous one, and the fibrocartilaginous one. And seronegative arthropathy involve only the fibrocartilaginous enthesis. Okay, so whenever the tendon, ligament, or capsule insert in the epiphysis or metaphysis, by definition, this is fibrocartilaginous enthesopathy. So where we can see the fibrocartilage, this is a typical enthesis, the attachment of a tendon, the Achilles tendon, into the bone, and you can see the different structure of the enthesis. So it likes the fibrocartilaginous part of the enthesis. This is where seronegative arthropathy like to be involved. Think of the fibrocartilage as the rubber hub that you get with your cable, and you can see the cable on the right side without this extra rubbery hub is deemed to be fail within few weeks. But when you add this extra rubber, you expect to have this cable to live with you furthermore, because it resists the traction and the pressure. Think of the enthesis. That's why it's very important to have our enthesis in our body to protect the tendon and as it's inserted into our bone. So if you apply the same thing with the Achilles tendon or the thing, you can see that the red tissue and where the tendon inserts, this is where we expect the enthesis, and we expect the fibrocartilage. And when there is also any contact between the tendon and bone, you expect to see fibrocartilage and enthesopathy and enthesis. Same thing in the finger. You can see whenever there is any contact between a ligament or tendon with the bone, you expect that there is a fibrocartilage tissue protecting the bone and tendon. That's why this is where they expect to see the inflammation. The other term that you need to be aware of is what we call a functional enthesis. This is where the tendon wraps around a bone. So to protect the tendon, you need this kind of extra tissue that protect the tendon. And we can see the most popular places is where the posterior tibial tendon is very close with the spring ligament. And you can see this structure I highlighted in blue is where you see the fibrocartilage. And when you can see the peroneus longus tendon wrap around the calcaneus, because these areas are considered also a function enthesis. So this is the potential places to see active peripheral enthesopathy or enthesis. So how you can image those patients? Mainly, the main modality of choice of scanning active enthesopathy is MRI. And we need to include a functional sequence and a water-sensitive sequence, whether the water-sensitive sequence is STIR or T2 FAT-SAT or T1 FAT-SAT with gadolinium contrast. Ultrasound is not good in showing early active enthesopathy. It's only for synovitis, but X-ray can also in later stage can show erosion and calcification. And this is how normal enthesis look like in different modality. In ultrasound, you cannot see normal enthesis because it's not visible. With normal MRI, you can see it. At center point, at some point, they try to do this kind of MRI technique called ultra-short TE, and you can see this publication was done in 2007, so more than 15 years ago. So till now, practically, it's not something that we use in clinical practice. But this is to show you that this high signal tissue between the Achilles tendon and bone, this is represent the fibrocartilage. So we can see it, but we still don't use it in our clinical practice. So imaging for to detect enthesopathy, you can see we can use MRI or ultrasound for different type of changes. So let's go through some examples. The typical place for peripheral enthesopathy, active enthesopathy, is the insertion of the Achilles tendon into the bone. And you can see here, you can see the whole changes in the Achilles tendons. You can see thickening of the tendon. You can see bone erosion, this tiny change in the back of the Achilles tendon. You can see inflammation of the bursa. So this is an indication of active enthesopathy of the Achilles tendon. And you can see on the right side an example of active inflammation of the plantar fascia. Ultrasound can show similar appearances. You can see inflammation of the tendon and bursa, but what ultrasound fails to show you with active enthesopathy is the marrow edema. So that's why, in my opinion, MRI have a better indication of activity of the enthesopathy, because you can see detected marrow edema. Further on, when the lesion becomes more chronic, you start seeing this kind of ossification and calcification in the tendon, which means this is a chronic enthesopathy. As I mentioned, you can see whenever the tendon or ligament is very close to the bone, whether it's functional or the tertiary, you expect to see this is a potential place of acute enthesopathy or active enthesopathy. And this is an example of reactive enthesopathy in patients with reactive arthropathy in the posterior tibial tendon. You can see here the whole changes, marrow edema especially. And this is what a good example of what I say, I told about this functional enthesopathy. This patient had a seronegative arthropathy, probably reactive, and you can see here on the right side of the thing, you can see the pronaeus longus tendon is inflamed as it crosses through the cuboid bone. And you can see here, there's still marrow edema in the cuboid bone. And this is just to provide, to support the idea of the theory of functional enthesopathy. Same appearances we can see in the joints of the hands. And again, this is explained why we see these places, inflammation. You can see there is a thickening of the insertion of the extensor tendon on the left side. You can see also inflammation of the annular ligament, what we call the pulleys, because they are inflamed. And we can see on the middle side, I don't know if you can, yeah, it's appearing. You can see the arrow here. You can see here there is inflammation of the extensor tendon, particularly the area which is close to the joint, because this is where the fibrocartilage is involved. So this is a sign of early active enthesopathy in these patients. So the other sign of peripheral arthropathy is what we call dactylitis, which is inflammation of the digit. And this is mainly seen in psoriatic arthropathy. And on those patients, we see the whole changes, or the whole expected changes of seronegative arthropathy. We see in enthesitis, joint effusion, synovitis, osteitis, and inflammation of the skin and soft tissue edema. In most of the cases, this is a clinical diagnosis. You don't have to do a scan because the patient is known to have seronegative arthropathy and present this with a painless swelling of one of the digits, which goes with dactylitis. But in some cases, when there is no diagnosis, primary diagnosis, this is something that we can pick up on imaging. And you can see here in this patient, on the left side, you can see inflammation of the extensor tendon, synovitis, and most importantly, you can see marrow edema with the bone, which is explained the osteitis. This is another patient who didn't have the diagnosis of seronegative at the time of the scan, but you can see here there is inflammation of the annular ligament, which extend beyond here to the sides, and here also, and you can see if you also see some osteitis of the middle phalanx. This is an example of dactylitis in patients who had later diagnosed with seronegative arthropathy. Plain X-ray can sometimes be helpful in early diagnosis when you see the hyperostosis and calcification. And you can see in this patient, we can see calcification of the annular ligament on the right side, and also some ossification. This is a sign of seronegative arthropathy. And in my opinion, when you start seeing this mixed appearance between ossification and calcification, at the same time there is erosion, so there is two opposite phenomena happening at the same time, bone erosion and ossification. This is a good sign that most probably this patient has a seronegative arthropathy, as opposed, of course, something like rheumatoid arthritis. Again, this enthesopathy can happen at any part of whenever there is insertion of a tendon or a ligament. And this is the progression of the calcification and erosion that we see on those patients. Start by inflammation of the joint capsule, and then you start having calcification and bone erosion. Then, because the erosion happened peripherally around the head of the phalanx, it ends by having this called what we call penicillin cup appearance, or you end by having this kind of ivory phalanx, which both are characteristic for peripheral seronegative arthropathy. So quickly, we'll go through the three main diseases with peripheral arthropathy, mainly psoriatic arthritis. This is something arthropathy that we see with patients with psoriasis. And it involves hands and feet mainly, especially the distal, the DIP and PIP joint. And it's very common to have, on those patients, it's common to have dactylitis. Okay? And this is how they presented in the plain X-ray. You can see, whenever you can see there is bone erosion and same time hyperostosis and bone formation, two opposing reaction happening, that means this is a patient with psoriatic, especially when it is happening in the peripheral joint, the DIP and PIP joint. And this is an example of also arthropathy and insertion of the one of the tendons here. And this is a sign of the dactylitis. Reactive is where secondary to GIT and urinary tract bacterial infection, and this consists of triad, conjunctivitis, arthritis, and arthritis. And they like to be involved the lower limb, so ankle and the feet. And dactylitis is very rare, and it is asymmetrical. The other one is enteropathic arthritis, which is secondary with Crohn's and ulcerative colitis, and for some reason they like to involve the knee especially, and I think this is one of the few cases I've got of enteropathic seronegative arthropathy involving the knee. You can see here there is erosion at the insertion of the iliotibial tract and also calcification. And the MRI showed there is marrow edema, which I mentioned is very good in, MRI is very good in showing marrow edema. And this patient had enteropathic seronegative arthropathy. And of course, I will not go through the ankylosing spondylitis because it's axial and not peripheral. And same thing with differentiated because it is involved the spine only. And this is just a quick overview about what I mean by peripheral or appendicular, which involve only the hands and feet and knee. And thank you very much.
Thank you, Dr. Ramy, for your presentation. Any question? Thank you.